Hi, evening everyone. Thank you all for attending this latest in our educational webinar series. Tonight we're going to be looking at the statutory duty of candour and what you need to know. Helping me this evening is my senior colleague, Dr. Edward Farnan. Ed is going to be manning the questions very kindly. So if you look at the control panel, it's a grey box. There's a drop-down section for questions. So if you could put your questions in as you go along, try and make them as succinct as possible if you can, please, and it means that we'll be able to get through more of them at the end. There will be just a few polls coming up through the presentation as well, so they will pop up with a yes, no, I don't know, basically option. If you can answer those as quickly as possible, just go with your gut when you see the question, then that's going to help us get a feel for what's going on in the room. Just a couple of housekeeping points. Your attendance certificate will be emailed to you from GoToWebinar within 24 hours. Recording of the webinar will then go on our YouTube channel and on our website within a few days. When you leave the webinar, you will get a pop-up for feedback. And if you could give us feedback, it is always really useful to help us planning future educational content and events. So if you took a minute or two just to say what you thought of the presentation and any other topics you would like to see covered in the future, that would be brilliant. Thank you. So by the end of today, what we are hoping to cover is these aims and objectives. The reason we wanted to cover this topic in particular is because although most practices have heard of the statutory duty of candour, it's one of those areas of medical law, I think, where we don't really think much about it until we're actually in a situation where the duty of candour is engaged, and then we have to learn really quickly. As you will know, that the MDU can assist practices with complaints. We can assist with lots of complaints. And sometimes as advisors, we see complaints coming through where we think the statutory duty of candour was triggered, but the practice haven't really considered that at the time that the complaint came to them, and so we have to help them work through the steps that they have to take to fulfil the duty of candour. So that was really why we chose this subject and thought it was important. So this is the aims by the end, is that you'll understand the professional or ethical obligation of candour. You will then go on to learn about the statutory duty of candour and how that differs. You'll understand when each duty may be engaged, what makes an effective apology, because that can be a sticking point for some doctors. And we will spend a bit of time at the end going through recent and upcoming developments. We have put in a few case scenarios, so we have some practical work to do just to see where the duty of candour applies, particularly the statutory duty of candour. And hopefully they're going to be interesting and get a bit of debate going. So why is the duty of candour important for doctors? It helps promote a culture of trust and respect with patients. Now, Ipsos Mori did a poll in 2021 where it polled the general public, asking a big list of professionals and said, how much would you trust this profession to tell you the truth? And right up at the top were nurses and doctors. Librarians were right up there as well, actually. They all had scores of over 90%. In that poll. Just out of interest, the bottom of the poll, unfortunately, was advertising executives, government ministers, and politicians generally. I'm afraid they all had scores under 20% for what they call the veracity index. So doctors are clearly held to be very trustworthy generally. And this evening, we're going to concentrate on how being open and honest when things go wrong can help cement the trust that you have with your patients. The second reason is that it helps promote learning from patient safety incidents. I think that historically secondary care has had a more formal approach to investigating patient safety incidents than general practice has had. So they have DATICS reporting where patient safety incidents get reported. Often in general practice, it would have been a complaint that triggered when I was in practice, that triggered our investigation. It took something to kick off the process, even though the process is much the same. I think practices these days are much more proactive in identifying patient safety incidents and in investigating them. And I have seen, certainly in the last recent months, some absolutely brilliant SEAs where there's been a huge amount of work done to look at patient safety incidents and learn from them. It encourages comprehensive documentation and recording of patient safety incidents, so we can then look for trends. Why are these things happening? Why do two things happen in a row that were the same? And of course, it's consistent with our ethical obligation of candour as a doctor. So I'm going to touch on the ethical duty first. This is what the GMC says that we must do, and when the GMC says must, it means that it expects us in all circumstances to adhere to this guidance. So we must be open and honest with patient when something causes or has the potential to cause harm or distress. You have to tell them when something goes wrong, you have to apologise, you have to put matters right, and you have to explain the long and short-term effects of what has happened. So that is the bedrock of our ethical duty of candour. As the GPs in the audience will no doubt know, good medical practice has been revised and the new GMC guidance comes into effect in January. So I thought I would just place that into the presentation too for anybody who's watching this on catch up after January 2024. So that's the wording of the new good medical practice chapter on ethical duty of candour. They've changed the order a little bit, and they've added a new obligation to report and to allow investigation in order to improve future care of patients. And that is a really important point. I think as we go through the presentation this evening, at the front of our minds is the fact that if we're open and honest with patients when things go wrong, and we can investigate and learn from these things, and we look at difficult cases where things didn't go as well as we would like, that is only going to improve our care of patients in the future. And I think the duty of candour can be the process that kicks off that whole learning process. So I think it's to be encouraged and embraced. This is the front page of the joint GMC and NMC guidance that was published in 2015. And the contents weren't new, but they brought it together to just to build on the existing guidance. There is a huge focus on apologising in this. When things go wrong for patients, we must apologise. We have to say, I'm really sorry this happened. It's an interesting document. It mentions near misses, which some of the statutory duty of candour don't concentrate too much on. And the GMC asks the question, do we need to tell a patient every time that there is an adverse incident, but that they don't suffer harm as a result because of some intervening event that averts the harm? The GMC says in those cases that we must use our professional judgment, and it says that there are circumstances, you know, where you certainly would want to tell the patient, look, I prescribed this drug, but then your pharmacist picked up the fact that you're allergic to it, so I'm going to have to prescribe you a different drug. But there are circumstances in which going through an adverse incident that didn't actually cause any harm, that's what a near miss is, could cause the patient unnecessary distress or alarm. So the GMC says we exercise our judgment in those cases as to what we tell patients and how much. And near misses are a source of great interest to people who work in patient safety. I know Sir Liam Donaldson called them in a publication of his free lessons. Basically, they're the times when something went wrong but nobody suffered, so they should be picked apart and learned from. And quite interestingly, Sir Liam also, in a different publication in 2003, was one of the first people who recommended a legal duty of candour for NHS workers. It didn't happen in 2003 when he brought it up, but we will see later in the presentation how it actually came to be. So this slide is just to show how your ethical duty of candour will apply in much more, you know, in almost every circumstance where something goes wrong for a patient, whereas your statutory duty of candour will only be engaged in a subset of those. There are very specific thresholds that we're going to cover in detail this evening that will trigger the statutory duty of candour, but the ethical duty remains. And CQC is the policeman, I suppose, of the statutory duty of candour. All registered healthcare providers, so trusts, foundation trusts, general practices, private facilities, they will inspect and expect all of those to adhere to the statutory duty. So I put this slide in. It's research that the GMC did when it was submitting to a Northern Irish public inquiry a few years ago. And this is what it wanted to highlight was what happens when patients or other people complain that doctors may not have engaged with their ethical duty of candour. So 3/4, as you can see, were closed with no action. Now that is not dissimilar to you know, the 60% or thereabouts of GMC complaints that get closed with no action of all complaints. There are lots that don't need any further investigation. A good chunk of these did end up with a fitness to practice hearing though, and it's just worth highlighting that. So that's the red piece of pie. It was 11%. The rest were disposed of by undertakings or warnings or advice. And those are pretty much the ways that the GMC will dispose of these. I'm taking a little step to the side, if you don't mind, just to speak about apologies, because they are a source of concern to doctors and to our members generally, I think. I had originally placed these slides further down the presentation, but I think I wanted to highlight early just a bit of advice about effective apologies. Some doctors have concerns that if things haven't gone well, and they then apologise for that could make it difficult to defend, for example, a claim subsequently. But there's loads and loads of law and guidance that makes it absolutely clear that that is not the case. It is not the case. That the Compensation Act applies in England and Wales. There's a very similar act, the Apologies Scotland Act 2016, which uses very similar wording. That says an apology itself is not an admission of liability. It is not an admission of negligence or breach of duty. So I think we need to take that anxiety from ourselves when we think about times when we're going to have to apologise. The patient's NHS resolution, which now handles claims against general practices in England, it has a very useful document called Saying Sorry, and it says it's always the right thing to do. It is not an admission of liability. It acknowledges simply that something could have gone better, and again emphasises that learning is the gold standard here. We want to learn from these incidents where things don't go well for patients. So if you think about how to deliver an apology effectively, I do realise that I am speaking to a room full of communication skills experts here, so this would probably all be very obvious to you. But face-to-face is generally best. Speak in the first person in normal sentences and as plainly as you can. Tell them what happened and why you think it happened. Don't go in with a script saying, right, I have to say this, I have to say this, and I have to say this, and then that's it all done. What you do is you listen, you feel your way. What does the patient want to know? What does the patient need to know? And think about privacy and about body language. But again, I realise I'm preaching to the converted in this particular audience. I think it's just as important to think about what not to say or how not to apologise. So don't say things like I'm sorry if, or I'm sorry but, or I'm sorry however, because that can appear to distance you from your apologies, and that's not usually what you're trying to do. If you wanted to distance yourself even further, you might start to say things like I'm sorry if you felt that I didn't do, you know, that's like putting 3 or 4 different word barriers between your apology and what happened. So just think about the language. So that is the ethical duty of candour, and I wanted to get that out of the way because I think we're all familiar with that and we can build on that. So I'm going to move on to the statutory duty of candour, which is in the main act this evening, and then the first of our poll questions. So poll will flash up for you. And the question is, how familiar are you with the statutory duty of candour? And that is just gut instinct. You're all here, I'm presuming, because you want to learn some more. But what are our what's our baseline here? So the answers are, I think, I'm very familiar, I'm not at all familiar, or I'm somewhat familiar. I'm going to give you a minute, half a minute to click that poll. Just go with the first one that you think applies. Right, and I think we're going to stop the poll there, and we're getting a very clear view that A few people are very familiar, about 20% are not at all familiar, and about 3/4 of you are somewhat familiar, and that is pretty much what we hear all the time and pretty much what we expect. So hopefully all of you, if you were to be asked that question at the end of the evening, you will have a different answer for that. So how did the duty of candour in England come to apply? It started off after the Mid-Staffordshire Trust inquiry by Sir Robert Francis. So in his very comprehensive report, he was critical not only of what happened for patients, but also about trust. One of his major criticisms were the trust staff were not honest with patients and the families about what had happened afterwards. And it was one of his recommendations is that a statutory duty of candour be introduced as a result of that. And on that occasion, that was quite quickly adopted. So the following year, England introduced a statutory duty of candour for trusts and foundation trusts. The following year, 2015, that was extended to general practices and private healthcare facilities. The duty applies to organisations, and it's
Claire, I do apologise for interrupting. We still can see the poll slide. I wonder if Caroline, who's manning that in the background, can stop sharing the poll.
Yeah, I'm just trying to do that now. Sorry, apologies, just doing that.
That's perfect. I go ahead then. So this evening's presentation is going to concentrate almost exclusively on the English duty of candour because there is so much overlap with the other jurisdictions in the UK. They are very similar in Scotland and Wales. A lot is similar in the proposed duty in Northern Ireland, but there are some very important differences in that. So Scotland's duty of candour was introduced in 2018. And again, is organisational. The Welsh duty of candour was implemented earlier this year in April. And again, it's very similar. It has a very slightly different threshold. So rather than moderate or severe harm, the Welsh wording is more than minimal harm. We'll cover a slide on that later on, just to keep people up to date. The Northern Ireland duty of candour has not been enacted yet, or hasn't been drawn up yet, but it's probably going to appear sometime in 2024, and there are some real differences with that one that we will drill down into at the end of the presentation. So the high level kind of principles of the statutory duty of candour is that it applies to organisations. It doesn't fall on any particular doctor or practice manager, although of course we're all involved in that. Apologies are central to the process. Written apologies have to be ordered in all jurisdictions where there is a statutory duty of candour so far. The duty is triggered.
Sorry to interrupt again. We're still on the poll, Claire. I think people are missing your slides as a result. I wonder if I can offer a suggestion. If maybe could you stop sharing your screen and start again, just to see if that would maybe help.
Yeah. I am pressing hide, but for some reason it's not hiding the poll.
Okay, is that me again?
It's come back again now.
Hooray. Good to have somebody technical on the team. Well, I go back through the last couple of slides. That was the one just setting out the differences between the 4 UK countries. And that was just the front of the Francis inquiry report. Hopefully you didn't need those to understand what I was saying. So this specific threshold of which is essentially moderate or severe harm, so that is what triggers the statutory duty of candour, and that's what sets it apart from your ethical duty of candour, which has a much lower threshold to be triggered. We're going to go and look at that in great detail shortly. And if the duty of candour is triggered, then specific actions are required. So the next poll, just as we got rid of the last poll, is now that you have seen what the statutory duty of candour is, do you think, have you ever been involved in a situation where you felt that something went wrong for a patient, but you just couldn't be open and honest with them about what had happened? So again, I'm going to give you a few seconds to click the poll and give us an idea. I'm going to open that up because I can see it happening in real time, which is quite fascinating. So it's about half and half so far. give it a few more seconds. Brilliant. So I think we can probably close that now, Caroline. So 60% of you are saying no, which is brilliant. 22% of you are saying yes, and we're going to look at some reasons why we feel that we can't be open with patients sometimes, and about 20% weren't quite sure. So it was pretty much 20-20-60 there, with 60% saying that they have always been able to be open and honest. Will somebody shout very early if the poll is appearing again instead of my slides?
It looks good now. Keep going.
Thanks. Right, this quite busy slide, which was much easier to read when I was wearing my spectacles, which obviously I can't have on camera on a webinar that's recorded. It's really just to explain that although the statutory duty falls on organisations, for it to be in any way workable, individual staff members will have to sign up to this. So they will need to be open and honest when things go wrong. They will have to know how to report things when things go wrong within their organisation, and that is then at that stage when the practice as an organisation swings into action. I think once embedded in our practices, it'll become standard, and it will contribute to the learning and just culture that we all want within our organisations. So I think if you want to put any questions about what the statutory duty of candour is, you can get those into the questions box. Now I'm going to move on to what happens, or what you actually have to do once you decide that the statutory duty of candour has been triggered. What do you have to do? So this is a summary slide. Again, I'm going to go into this in greater detail shortly, but basically what you have to do, it reads a wee bit like the GMC guidance. You must tell them as soon as reasonably practicable that a patient safety incident has arisen. You must explain fully what is known at the time. You must give an apology. You must keep a written record of the notification to the patient and provide reasonable support to the patient. And of course, you must then go and investigate and write to the patient with the outcome of that. So that's pretty much, we're going to go through this a few times because it's something you're not familiar with until you've had to do it, or probably had to do it once or twice. But I will come back to that later in the presentation. This is another big chunky bit of knowledge that we need to carry forward with us into the presentation. So this is the definition of what triggers your statutory duty of candour, or of a patient safety incident, a notifiable patient safety incident, and that is any unintended or unexpected incident that occurred in respect of basically a patient, and the regulated activity is providing healthcare that appears to have resulted in death, an impairment of sensory, motor or intellectual function that is going to last for more than 28 days, changes to the structure of the body, such as amputation of a limb, a prolonged pain or prolonged psychological harm, and again the threshold for that is longer than 28 days or likely to last for longer than 28 days, shortening of life expectancy, or with reference to all of the above, treatment that has to be provided by a healthcare professional to prevent any of the above evolving. So there's a couple of things I would just highlight. The first is in the very first sentence, is the use of the word or. So it's an unintended or unexpected incident. It's not an unintended and unexpected incident. So if you think, sometimes it's useful in this scenario to think about something like a recognised complication arising after a procedure. Say you do a minor op and you will consent to people and tell them that certain things might happen. You would not intend that to happen to them. But they can arise, and I suppose you couldn't really call it unexpected, because if you're warning them about it beforehand, you're expecting it to arise in a certain small number of cases. So those types of cases would get covered by the statutory duty and would trigger it. And we're going to speak that one of our case studies pertains exactly to that point. And one of the other case studies pertains to the very last point at the bottom. So you don't have to die or experience serious harm. If you need additional treatment to stop that from happening, then that also triggers the duty of candour. So those are the two big, the top and the tail, I would highlight as important. The definitions I am going to summarise these again in the following slides, and these are for the visual learners like myself. I like to see things not in big wordy slides, I like to see them in smaller slides. So death, we will know what that is, and that is only where the death relates directly to the incident. It is not where a patient had a terminal illness or a serious illness and was going to die anyway and died as a result of the illness. It's only if they took a turn for the worse as a result of the incident. Shortening of life expectancy, that should be clear. The thresholds, an impairment of the sensory, motor or intellectual function which lasts or is likely to last for more than 28 days, changes to the structure of the body, prolonged pain, that's over 28 days, prolonged psychological harm, again, that will last or is likely to last for more than 28 days. And very importantly, keep this one in your head, if you need treatment to prevent any of the above, then the statutory duty is triggered. So now that we have those definitions firmly in our brains, I'm going to ask you another question. Caroline's going to do the poll. So have you been involved, now that you know what a notifiable patient safety incident is, have you been involved in a notifiable patient safety incident that triggered the statutory duty of candour? I suspect the answers are going to come in a kind of line graph depending on how long we've been in practice. There must be a cumulative number, a cumulative risk of being involved in a notifiable patient safety incident. So let's see how we're going so far. I think we'll wait for a few more votes and the yeses are creeping up. I'll just give it a couple more seconds. This is fascinating to me. I know you can't see this, but it goes up and down. Yeah, so I think we're going to stop it there. And it is basically coming up as 1/3 yes and 2/3 no. So 1/3 of us know that we have been involved in a patient safety incident that was serious enough to trigger that statutory duty. 63% so far no, and that's pretty much what we expect. So we now have the thresholds in our heads and we're going to remember those, and we are now going to go on and look at a few case scenarios. So I'm going to read them and I'm going to talk through them. I think it's too difficult to put stuff in the chat that answers these, but if there are any questions arising, put them in the questions section, please. So a patient has an excision of a sebaceous cyst. He develops a wound infection and requires 10 days of antibiotics. So if we think about the threshold, it's definitely not death. It's not changes to the structure of the body. So can we think that any of the threshold of the duty of candour might apply here? I've kind of deliberately started with the most finely balanced one because these are the ones that will cause difficulty. Rather than the barn door obvious cases where the threshold is or is not reached. You might consider here that it required treatment to prevent either prolonged pain or distress. It's not the definition of prolonged pain or distress, but you might say that those antibiotics stopped it going on for 28 days. So we think we need a little bit more information on this one about what exactly was needed and what the outcome was. And at the minute, from the information we have, we think that both of those might apply, that it may or may not apply, and that the details of the case would probably decide that for us. So I'd be interested in your thoughts on that one. Next case we're looking at is a patient was told by the doctor that a lung lesion on their x-ray was likely to be cancer. The patient had presented very ill with weight loss, and the GP was almost expecting something bad to come back on this x-ray, and there was a lesion on it. So in order to try and prepare the patient, he referred for an MRI scan and told the patient, I'm sorry, I'm going to have to tell you, I think this may be cancer. Happily for the patient, the MRI shows that the lesion was actually an artifact and that it's not cancer at all. And obviously this is a great outcome for the patient. But when he comes back to see the GP, he says he's been very, very stressed over the 5 weeks that it took to get the final answer. So do we think that that might work or impinge on any of the thresholds? And you know that I've put 5 weeks in for a very good reason, because that's longer than 28 days, isn't it? And I would call that prolonged psychological distress, prolonged psychological harm. And I think that does, in fact, trigger the statutory duty of candour. So next case scenario is a GP who's injected steroid into the knee joint of an obese lady with rheumatoid. and she develops a burning pain on that side of the knee shortly afterwards. She sees her rheumatologist about 10 days later, and the rheumatologist says that the injection, she fears that has damaged the saphenous nerve of the patient, probably because the obesity and the anatomy just made it very difficult to identify the landmarks properly. So the pain was thought likely to become chronic at that stage. So can we think of any of the thresholds that might be reached by that scenario? We're thinking it does reach it, and we think it's because of prolonged pain. The pain doesn't have to have lasted 28 days, it has to be likely to last for 28 days. So that's why that triggers the duty in this occasion. So next is a patient who was inadvertently given unopposed estrogen for menopausal symptoms. She presented then with postmenopausal bleeding, and that required referral and treatment in hospital. And the patient was very anxious during this period because she feared the worst. So do we think that triggers our duty of candour, and on what grounds? I would say it does certainly on one, and that's in the additional treatment that was required, and probably on prolonged psychological harm, depending on how long that lady has been anxious for. So that's a tick for that one. The last case that we're going to have a look at is a GP who knows a 71-year-old lady very well, suddenly starts to experience memory loss, and her family are reporting her acting very strangely. The GP believes that the patient probably has dementia and refers her to the dementia service. When she's seen there, she's worked up for dementia, but she was re-evaluated sometime later, and they actually found out that she had depression, which responded very well to antidepressant treatment. So do we think that the threshold applies in this case? I think it does, because that could be prolonged psychological distress. So that's the scenarios that we have. And now that we've been through those scenarios, I'm going to give you another poll question because I like those. So if you've been looking and listening very carefully, you will hopefully know the answer to this one, and that is, do known complications trigger the statutory duty of candour even if they were discussed during the consent process? So if you can give your responses to that, and I would like to see a good chunk of people getting the right answer here. And I am seeing that, that's brilliant. Just keep the votes coming. So this is, if you think about the lady with the knee injection, if you had said to her beforehand, I can't, the anatomy is difficult here, there's a possibility I could damage a nerve by going in here, even if you wouldn't say that normally, would that still, if she got the pain, would that still trigger the duty of candour? So I think we're going to stop the poll there, and we have a good 3/4 of people who are saying yes, absolutely, it still would. And that is quite clear. I'm going to just mention the case where that's exactly what happened. And this was one of the very few prosecutions that the CQC has brought under the statutory duty. They prosecuted a hospital trust for not following the duty of candour process properly after a patient developed a known complication of an endoscopy, that was perforation. The CQC does not prosecute very often. I think there's only been this and one other prosecution of a private hospital. That was in 2021. They have issued 17 fixed penalty notices, I think, on occasions where they could have prosecuted, but they felt it was more appropriate to issue these fixed penalty notices. But it's just to highlight the fact that it is a focus of attention at the minute. And so it's one you do want to be aware of. So that is finishing this section on the thresholds that trigger the statutory duty of candour. If you have any questions about that, will you put them in the box? And we're now going to look in greater detail about how you actually discharge the duty of candour. What does the practice need to do? If you get a complaint or something happens and you think, right, this is right in the territory that triggers our duty of candour, what do you do next? So I've summarised it. I'll talk a bit to this slide if that's okay. Just checking time is okay. So the registered person must, as soon as reasonably practical, note notify the patient in person or their representative in person that a patient safety incident has occurred. You should explain what is currently known. I would say don't speculate on what you don't know, because things can look really different after you've had a good look at them. Tell them what you know, but say that this may change. This is our current understanding. You tell them what further inquiries are going to be carried out, who's going to investigate, when they might find out more. Is it going to be a long time or a short time? And you should keep the patient updated with your progress. You must include an apology at that meeting. You must say the words "I am sorry," or you won't have discharged your statutory duty. You must then give a written summary of the notification of the statutory duty of candour being triggered to the patient, and then obviously after that you will write to them with your report and explain what happened, why it happened, what you've done to stop it happening again. And again, we would say repeat an apology in there for the upset to the patient, and you should keep everybody well informed throughout those. You may need to support your staff, and you may need to support yourself, because these things are stressful. This is some research that the PSA did a few years ago. So the PSA are the Professional Standards Authority, and they oversee the work of professional regulators like the GMC, the GDC, the NMC. So our regulators, the PSA is a layer above that again. And they wanted to see what sorts of things stop professionals from engaging with their professional duty of candour, and they found that it was the fear factor in all cases: fear of litigation, fear of regulatory action being reported to the GMC, or fear of it going public or going into the media. So sometimes people think, if I don't start this process, if I don't tell the patient that something went wrong, none of these bad things will happen. However, they also found that there were very definite enablers to people engaging in their duty of candour, and that was an open and just culture. So that is working in an organisation where patient safety incidents are looked at dispassionately, where fingers are not pointed at individuals, where everybody just wants to learn the heck out of what happened and then make things better for the rest of their patients. Timely action, so good, quick but thorough investigations tend to be much more enabling than long drawn out investigations, which are stressful for everybody. And where organisations invested in good education and training so that everybody knew exactly what they were supposed to do, then more professionals were able to engage with their process and with the duty properly. This is another piece of research that was done after the statutory duty of candour was introduced in England, and it was done by Manchester and Birmingham universities and by the Nuffield Trust. And they found that there was a measurable increase in openness of culture within organisations since the duty of candour had been introduced. There was increased patient confidence. They believed they would actually be told if things went wrong, and that there were net reputational benefits to the trust. So those are tangible benefits. This was mainly done looking at trusts and duty of candour. Unfortunately, that did not translate into an impact on the bottom line. So there wasn't a huge change in the number of complaints or litigation rates, but that was relatively early in after the introduction of the duty of candour. It would be interesting to see that research repeated to see if that has changed. Basically, the research says do it. It'll make patients more confident. It mightn't stop complaints arising, but there are definite benefits to this. So I'm going to move on just to a little section on the different jurisdictions. I thought I should put something in because the Welsh duty of candour went live in April, and so our colleagues in Wales will be finding their feet with this. It's really similar to the English statutory duty of candour. It applies to local health boards, primary cares and NHS trusts. The harm threshold is worded slightly different. So if you remember, the English threshold is moderate or severe harm. The Welsh wording is more than minimal harm, but it translates into really much the same thing. And again, the organisation must follow specific steps that are broadly similar to the steps in England. That is, they must apologise, they must explain, they must offer support, they must explain what will happen next. They must provide a named contact for the patient, and they must write within 5 working days about the notification to the patient. They then investigate, and in Wales they must follow the putting things right procedures. So that's it in a nutshell. I'm very happy to discuss that a wee bit in greater detail if necessary, but I'm keen not to overrun too much here. The Northern Ireland situation is different again, and it is a cause of some concern. That you may have heard of the hyponatremia inquiry. It went on for over 10 years here, and it looked into a small number of deaths following very sad deaths of children after they were transfused with hyponatremic fluids. Mr. Justice O'Hara made a series of recommendations at the end of that report, including the introduction of a statutory duty of candour on organisations to Northern Ireland. What he also did, which went further than anyone had done before, was to recommend an individual duty of candour. That would be a first for any country in the UK. And I think what has caused even greater concern to the MDU was the recommendation that criminal sanctions should be attached to the statutory duty of candour. So it would be a criminal offence to breach your duty or to obstruct another person in the performance of the duty. So that take things to another level. The Department of Health consulted on this, and at present they are indicating that they expect it to be applied in only the most severe of cases. But it is a cause of alarm, I would say, to us and to lots of other organisations. I'm going to just mention a previous set of deaths where healthcare was criminalised, and what happened as a result of that. So this was years ago, and it was a series of deaths that occurred over several years when a drug called vincristine was injected intrathecally rather than intravenously. So doctors were prosecuted and convicted for these deaths. However, the deaths continued despite that. What happened in the end is that basically the measures were put in place that made it physically almost impossible to put the drug into the wrong port, to put the drug into the wrong place, and that's when the deaths stopped. So we feel that strong systemic measures are what help patient safety, that putting doctors in the dock, so to speak, will not unfortunately accomplish that. And in fact, we've now seen the research that shows what the barriers to engaging with duty of candour is, and that's fear. And if you add to that the fear of a criminal prosecution, you can see how that might be putting barriers up and might actually be a backward step. The consultation on the duty of candour closed about 2 years ago, and the MDU made a big contribution to that. You can see it on their website. It's a really interesting and very well thought out contribution to the public consultation. However, the Department of Health has not responded or issued its response yet, but unfortunately the indications are that since all political parties here seem to be supporting it, slightly unusually perhaps, that there will be an individual as well as an organisational duty of candour, and that there will be criminal sanctions attached. Unfortunately, the MDU will no doubt continue to voice its concerns on this front, but that's the situation at present. So this is my summary slide. Basically just to say, professional duty of candour, that's our ethical duty of candour, is effective, it works, it helps us be open and honest with patients. The statutory duty of candour applies in fewer cases, and it has specific thresholds, and it has specific processes that we must follow once it is triggered. The inhibitor of engaging with duty of candour seems to be fear, and the right organisational culture seems to facilitate it. There's not much research available on the impact of the statutory duty, but what there is positive in some areas. It doesn't really show a decrease in complaints or claims, but that may be to come. Fear and openness, I think, still pull in different directions in these circumstances, and there is no evidence at all, and in fact there's evidence to the contrary, that criminalising healthcare will reduce harms. So that is the end of the presentation for this evening, and I think Ed is going to join me so we can start to get to the interesting part, which is the questions. So Ed, when you're back on screen.
I am back. I'm back. Thank you very much, Claire. That was really interesting. A lot of questions have come up, in particular, as you would imagine, arising from some of the scenarios. I think we picked the scenarios in many cases not to be particularly clear or black and white, because clinical practice isn't black and white. There's often a debate to be had. A couple of the scenarios here. One, the one in particular which has triggered questions is the chest X-ray one, where the patient had an artifact on the chest X-ray, and then that caused some anxiety while that was trying to be resolved. So the first question was that we often discuss possibilities and further tests which will give more information, and this is always stressful for patients while they're waiting for that, particularly given the time frame for appointments being as long as they are at present, and wondering whether that could affect a more frequent triggering of the threshold. The second question, which sort of follows on from that to an extent, is with regard to the chest X-ray example, is it not important to tell a patient that you're worried that maybe cancer is evident, and therefore it's important to attend for further imaging? So I think what I would say to that, I mean, interrupt me if you think I'm wrong, Claire, is that there is a responsibility to be open and transparent with the patients in these situations. You're not responsible for things that you're not responsible for as the patient's GP, for example. There is an abnormality in this chest X-ray. It does require further investigation. You'll tell them why you're worried. If it transpires that the abnormality was an artifact and that the worry was perhaps unnecessary, then you will need to be transparent. But it may also be important in those situations to involve secondary care, for example, the radiology team, the respiratory team. This is a duty which can cover various organisations, not just one.
Yeah, I think that's right, Ed. And actually, when the slide was written, the word "is likely to be cancer" was chosen on purpose so that it triggered that. So that was a slightly artificial manoeuvre on my part, because I don't think we would say this is likely to be cancer in the real world. We would say it's one of many possibilities. I'm sorry, you know, it could be anything, it could be nothing. If the patient said, "Could it be cancer, doctor?" you're going to say it's a possibility. I don't think we would say it's likely to be cancer, but if you did and the patient then said, "Well, you told me it was likely," I think that it would be triggered, perhaps not as we would phrase it as GPs.
Yeah, absolutely. The other one which caused a question was the sebaceous cyst one, the sort of the wound infection post-operatively after minor surgery. And you know, a minor wound infection, I think, is not that unusual. May not necessarily trigger the statutory. I think we're looking at probably something like a more severe infection, perhaps somebody who needed to be admitted for intravenous antibiotics. That's more likely to trigger. Yeah,
definitely, or debridement or something. So that would then be right in the realms of statutory duty. A little bit of erythema around the scar definitely wouldn't be if that went away with 10 days of antibiotics. So again, it was just to show that there are all sorts of facets to the same type of case. And I suppose I would highlight at this stage that if you ever find yourself thinking, "Gosh, I wonder, is that engaging my duty of candour?" you lift the phone and speak to one of your advisors. We have a 24/7 helpline, and we're always happy to chew over these cases and say, "Yes, I think that sounds like it might be over the line." So those are ones to discuss with your defence organisation for sure.
Another question was come up sort of slightly earlier. I think you did sort of touch on this, but essentially the question was, is it okay to say that you don't know why an incident has occurred?
Yeah, much better, I would say, to say that you don't know why than to say, "I think it was because of this," and then find it was something completely different, because that's confusing for the patient. So you say, "Here's what I know so far." If you know really little so far, that's all you can say. Say, "I can see that this has happened. We are going to have to dig and see why it happened."
Yeah, I think the point there is that you're having this conversation because it's possible that something has gone wrong. This is your chance to sort of re-establish the patient's trust. If you say something which turns out to be wrong and you know that it was likely to be wrong at the outset, you've lost that opportunity to rebuild trust. If you're open and transparent that you don't know that much at the start, but you will update them as the investigation goes on, for example, that I think being open and honest about not knowing something is much better than speculating or guessing the wrong answer.
I think so.
Somebody asked, if it is the case that we're going to have to keep a written notification about this, about what you've told the patient, where should that be kept? Should it be in the records or should it be elsewhere?
That's a good question. I would say that there is a case, if it relates to the care of the patient ongoing, if the clinical care is going to be affected by it, then I would say you should probably put a summary of it in the patient's records. But I would say there's a case to be made for having a little statutory duty of candour investigation file and keeping anonymised copies in there. But I'd be interested in what you think, Ed. That's a question that comes up in all sorts of places. Do we put this in the notes or not put it in the notes?
Yeah, the other place where that often comes up is in terms of complaints correspondence, and I think in general what we would say is or warning letters to patients. Generally speaking, that shouldn't be kept in the clinical records. If there's something which is specifically clinically relevant, then a clinical note to that effect should be added. But the other stuff, the warning letter, the complaints correspondence, the duty of candour correspondence should be kept securely elsewhere.
I agree.
And again, this comes back to thresholds, I think, is you mentioned the fact that unintended or unexpected outcomes or side effects or consequences should be triggering the duty of candour. Does that apply to every side effect if a patient develops it?
It doesn't, because if I could take you back to my slide, what it says is anything unintended or unexpected that results in death, prolonged pain, prolonged psychological pain. So that's just the coverall top part of the definition, and then it has to cause either moderate or severe harm or death in order for the duty to be triggered. So minor harm, no, would not. That would trigger your ethical duty of candour, but it probably wouldn't trigger the statutory duty of candour with all the steps that you then have to go through.
And that comes back to that sort of Ipsos Mori poll, which is that doctors are regarded as being open and trustworthy and honest with their patients. That's where the professional and ethical duty comes in, because if somebody develops something, your natural instinct, I think, is always to tell them what's happened and why, even if it doesn't necessarily trigger the statutory duty with all those other specific requirements that entails. One question and I think this comes back to the fact that it's organisations which are responsible for the statutory duty, which in secondary care will be the Secondary Care Trust or the Health Board. In primary care, that might be the individual clinician if the individual clinician is also a partner in the practice. And that's one of the differences.
Yeah, that's a good point, Ed.
And then somebody else has asked, what should a doctor do if they report an incident to their employing organisation which they think might trigger the statutory duty and the employer doesn't act accordingly?
And that is an interesting one. That would trigger there's other GMC guidance about raising concerns. It's called Raising and Acting on Concerns about Patient Safety, and it's on the GMC website. So what that says is if you have concerns that patient safety may be at risk, then you must raise those concerns. And if no action is taken, you must continue to raise the concerns until somebody actually does something to fix the problem that you can see. So that is quite clear, and that is a duty placed on doctors by the GMC. So you would be expected not to just say, right, well, I told the GP partner, so now that's going to be all sorted. If you see it isn't sorted, you have a duty to keep raising the concern until some action is actually taken.
Yeah, I think you've discharged your duty by raising the issue in the first instance. You can't make the organisation do something that you think should be done. But if you think that they haven't acted appropriately, then raising it again, raising it through a different line of communication. Secondary care, for example, will have things like freedom to speak up guardians. If necessary, you can always take that to the CQC. That's a sort of a fairly significant option to consider. Those are the sorts of cases where I think people would be very welcome to call us for advice about what the steps they should be taking before they feel that they actually have to take them.
Yeah.
One other question, and you did touch on this, but I think some people weren't able to join at the very start, was this concept of an apology. And I think we were very clear that an apology is not an admission of liability. It's not necessarily accepting blame for something. Can you go over again? Somebody had a question about the sort of the I'm sorry if, I'm sorry but, that sort of conditional apology.
We see these all the time in complaint responses, which we see lots of. It's if you say I'm sorry that this thing happened to you, that's an apology. I'm sorry that happened. If you say I'm sorry if you feel that I was rude to you during that consultation, or if you think you got that wound infection because of my operative technique, those are words that distance you. They're putting barriers between you and your apology. An apology should say, I'm sorry this happened to you. You're speaking human to human and doctor to patient, and you want it to come across as personally and as honestly as you can. So the words just creep in. They just creep in all the time, and we spend a lot of time, fishing them out again, or asking doctors whether they would take them out again, because they do water down the apology. There's no two ways about it. And there are loads of celebrity kind of bad apologies. You can read them on the internet. There's some seriously bad apologies, but they all seem to say, I'm sorry if, or I'm sorry but, I'm sorry however you did come and see me. And so it's just, nobody sets out to do that. When we write a letter, we are going to say sorry, but they just seem to creep in.
I think that the Ombudsman, for example, certainly the English Ombudsman in previous reports has specified that is what represents, in their view, a false apology, and has criticised doctors and healthcare organisations for including that wording. So, if you're unsure about what way you should word an apology, again, we're more than happy to help with that, to make sure that it's a sincere wording, but one which does not sort of open other doors of complaint for you.
Yeah.
I think we've touched on pretty much everything that's been asked. I don't think there's anything we haven't sort of addressed. I don't know if you have anything to add to what we've said.
I don't think so. I hope that everybody has left with a greater understanding of it, because we get lots of practices who send us complaints and we write back and say, well, here's a bit of advice on the wording. Have you thought about whether that might trigger your duty of candour? And they genuinely just, because they've never had to do it before, they haven't thought of it. So a big part of tonight is just getting a little seed planted in your brain, so that the next time, and hopefully not too often, that a patient safety incident arises, you would think, gosh, I think that might be a threshold, that could be prolonged harm, that could be prolonged pain. I think we're going to have to look at this and then do the steps. We have a really good guide to the duty of candour on the MDU website. It's really good step-by-step advice, and we also have a 24/7 helpline with medico-legal advisors who will walk you through what you need to do. So I would strongly advise that those cases are worth discussing with us one-to-one.
Absolutely. I mean, I think there's one more question just has cropped up as we finish. If a patient says, are you confirming that you made an error after you've made an apology? What would you advise to respond? And I think that very much depends on whether there was an error. Yeah. I think if you've made a mistake, you should say that you made a mistake. It doesn't necessarily mean that there's any liability there. Again, we can help with that. Sometimes you'll be apologising because something went wrong. It doesn't mean that you made a mistake. As we've said, recognised side effects might trigger an apology. It doesn't mean that something went wrong. Things go wrong even with the best clinical care. Medicine is not always an exact or precise science.
Mm-hmm. I think if something has gone wrong and you know that you made an error, I would go further and say that you could actually be criticised if you don't acknowledge that right at the start. And there's nothing to be lost by saying that, as long as you're sure that that's the case, and you're not, it's not conjecture. If you know that you gave some penicillin to somebody who's allergic to penicillin for whatever reason, you would say, I'm really sorry, I made an error, I gave you the wrong medication, because the facts are clearly obvious, and to say I don't know what happened at that stage might not be the right way to approach it.
I think so. The only other thing I would say is that if you think that the duty of candour applies, whether it's the professional duty or the statutory duty, I'm not aware of anybody who's been criticised for applying it when it didn't apply. I'm aware of organisations and doctors who have been criticised for not applying it when it should have been applied.
Yeah.
You have a low threshold if you're in doubt.
Yeah, a cautious approach. There's nothing to be lost from that. I agree.
I think that brings us to 8 o'clock, or just a minute short.
Good. Well,
thank you very much, Claire.
Thanks, and a real thank you to everybody for turning up this evening. It's lovely to see so many people here. I hope we covered most of what you wanted and expected, and hopefully we will see you at one of these really soon. Thank you.
Bye-bye.